Well, hi everyone. Thanks for joining our hot topics tonight on collegiate health with the Maine Dartmouth Family Medicine Residency Program. I'm Scott Allen. I'm the CEO for the Family Medicine Education Consortium. And if you haven't joined one of these, just want to give you a little bit of background on FMEC before I turn it over to Dr. Wooler to talk about collegiate health and the Maine Dartmouth Family Residency. So we are a regional coalition, about 14 states and DC in the Northeast US. In that region, we have 60 medical school departments of family medicine and about 190 family medicine residency training programs. So we work with all of those through the 14 states. Our big activity, which you may be familiar with, is we do an annual meeting each fall, bring about 800 to 900 people together. And that includes 300 medical students that we bring on scholarships. And one thing that they can do is meet all the residency programs at our residency fair. We just wrapped up our annual meeting about a week and a half ago in Arlington, Virginia, and we had 89 family medicine residency programs represented. So we have a very bustling residency fair. We also do a series of awards for both family physicians who are doing innovative and exciting work, but also for some things like creative writing, like prose and poetry. We have some learning collaboratives that are addressing different clinical topics to help improve how we practice medicine, and lots of volunteer opportunities for you to get involved with the SMEC. We are a catalyst convener and incubator. We promote family medicine and primary care professions to medical students. We help residents transition out into their careers, and we connect family medicine faculty and program directors to help them learn from each other and improve their training. And with that, I am going to say, join us next year in Rhode Island at our 2023 meeting in Providence, October 13th through 15th. And now I'll turn it over to Dr. Wooler.
Great, thanks, Scott. And my colleague Caroline Lefebvre and a future college student in her lap have also joined us for this evening's presentation. I'll go ahead and share our screen just so we can get things started here. So Caroline and I are from the Maine Dartmouth Family Medicine Residency. We are up in Maine. We have clinical sites in Augusta, Maine, which is the capital, and Waterville, Maine. And one of our community partners up in Waterville, Maine is Colby College, which is a small private liberal arts college. Well, our two residency clinics in Waterville and Augusta are more traditional residency clinics where we serve a wide range of the local population. We're a rural state, so many of our patients come from the small rural communities around both Waterville and Augusta. And we also take care of under-resourced populations in both of those small cities. In Augusta in particular, we have a recent refugee and immigrant population. And so we take care of a pretty wide range of population. But part of our local community, particularly in Waterville, is this small liberal arts college. And so now about nearly 3 years ago, we started becoming the providers of care for the students in the Student Health Center. And there are some really interesting and unique things about treating a population like a population of college students that both Caroline and I have learned a lot about, and we've had the privilege of teaching our residents about some of those unique aspects of working with a population. And we want to share some of those thoughts with you this evening. We're a small enough group, if we could just real quick, maybe have you introduce yourselves to us. And tell us where you are and what stage of your medical education you're at. I'll just call out some names that I can see. Jamal.
Hey, how's it going, everyone? My name is Jamal Moss. I'm a fourth-year medical student at Meharry Medical College down in Nashville, but I'm currently doing an away rotation right now at UPenn for family medicine. Happy to be with you all tonight.
Awesome, great, welcome. Gabrielle.
Hi, I'm a third year from the CUNY School of Medicine in New York. Also stopped by the booth during the FMEC annual meeting. So nice to see you guys again.
Great, thanks for coming. Oyemi, did I say that right?
Yes, perfect. So, but you can call me Yemi. So I'm a Nigerian trained physician. I graduated from medical school. I currently reside in Rockville, Maryland, and I scribe for a family physician in his clinic. So that's what I do currently. I'm happy to be here and nice to be with
Great.
you.
Thanks for joining us.
Thank you.
Olamide, did I say that correct?
Yeah, you did well. I'm also a Nigerian trained physician. I did a postgraduate in OBGYN also in Nigeria. I have been working in the UK. I only came here to get some American experience, and I'm applying for family medicine. I got to know about your program during the FMEC, and I'm very, very happy to be here.
Great, welcome.
Yeah.
Is it Folake?
Hi everyone, my name is Folake Adeleye. I'm a Nigerian trained physician. I currently live in Washington, DC. I work as a clinical trial coordinator. I was at the FMEC and I'm really glad to be at your program today. Thank you.
Great, thank you and welcome. Brianna?
Hi, everyone. My name is Brianna. I'm a fourth year student at PCOM in Philadelphia, who I've had the pleasure of meeting a few of you. Hello.
Awesome.
I learned about your program at AAFP and saw many of you again at FMAC. I think you have just a truly special program. So I wanted to hear what you guys are teaching about tonight.
Awesome, great, well, welcome. Thanks for joining us. I'll just introduce myself real quick. My name is Raj Wolliver. I'm the director at Maine Dartmouth. I've been there for a little over, or almost exactly 4 years. Prior to that, I was a director in another program in Maine. I did my residency in a U.S. Air Force program out in California. My wife is also a family physician. We were in the Air Force and lived in California and then Florida and then Germany. And then settled back down in Maine about 16 years ago. Caroline?
Hi, so I'm Caroline Lefebvre. I did my residency at Maine Dartmouth and joined the faculty a little over 2 years ago. I am from lots of places, but Maine more as an adult. So I actually went to Colby College that we now partner with. And when I was looking for a residency program, wanted to pick the one that was the best for my training. It happened to be that my husband was teaching and still is teaching at Colby. And so the fact that Maine Dartmouth was so close was actually a negative. I didn't want to pick the closest place. I wanted to pick the best place. So Maine Dartmouth just happened to be there. And the fact that it was down the road from where my husband worked was a wonderful stroke of luck. And this is Lyndon Lefebvre, our youngest of three. She is almost 9 months old and bedtime did not go as planned. So she is joining us until her sisters are asleep. So yes, but we'll see.
Lyndon is a Zoom pro. She's been on Zoom since like day 4 of life, I think.
Yeah. Yeah, so we'll see. Yeah, she didn't want to go to sleep. So.
All right, so as I said, we're going to talk a little bit about collegiate health and some of the unique characteristics of caring for a young, well-educated population who lives in very close quarters. So that makes you think a little bit differently about how you're going to manage some of the common healthcare concerns that you might encounter when you're working in a student health center. Caroline, I have control of the slides, so I'll advance as you direct me, but we'll.
Yeah, sure. If you want to go to the next one. So we are a rural program based in Maine. Maine happens to be a very old white state, which should come as no surprise when you look at demographics of the state, and our clinic panels look that way. We do have a few, like Raj mentioned, pockets of refugees, both in the Augusta site and some in Waterville. Colby adds a little bit to that. So Colby is a liberal arts school. It's undergraduates only, and currently have 2,200 students from all across the country and globe. About 27% of them identify as students of color, and about 8 to 10% are international, and 10% of students are first generation college students. Additionally, interesting things that add to the problems we see: about 2/3 of all students will study abroad at some point during their time at Colby. So we do some travel clinic type work, and lots of them play sports. So about 30% play sports. So you deal with sports injuries, clearance for sports, eating disorders, that kind of thing. So, yeah.
I just one thing to highlight here is that even though Colby is a private liberal arts college, this is a more diverse student body than the local area. So one of the benefits of having the opportunity to work with this population is it's actually a more diverse group. And so we have an opportunity to not only work with them in the student health center, but also have a chance to interact with them on campus with their pre-med group, and think about how we can work with them to encourage future careers in family medicine from an earlier point in the pathway on the medical education route.
They are also, by fact, usually between the ages of 18 and 22. So fall in our more adolescent health. So while technically are all adults, really trend more towards the adolescent side of things. So a bit about the health service, or the health center. So we do lots of different things there: general medicine, nutrition, reproductive health, psychiatric, sports medicine, travel health. We have nurses that work there. And then there's counseling services that's also based at the health center as well. And then we have joined recently. So this is just, we had some changes in the hierarchy of things as we took over. So the health center at Colby used to be run by, there was one medical director who was a Colby physician employed by Colby, who had several PAs and NPs that worked under him. And it was a separate freestanding clinic that they ran that way with several RNs. And then when that director left, we as Maine Dartmouth took over and changed the hierarchy a bit. So we do have a medical director, but have recently moved to, instead of being based on campus, we have nurses based on campus, and then students are coming down it is a literal hill, it's a big hill, down the hill to our outpatient office that's based at Thayer Hospital. Is this sound okay? I'm sorry, it feels echoey. Okay, okay.
It's going fine.
Okay.
If any of you are familiar with sort of the student health setup on many college campuses, it varies quite a lot. And while I think historically, most of them were probably more like the old model at Colby, where it was a single provider, usually a physician employed by the college, working out of, in many cases, in like an old house or structures that wouldn't really qualify as a true medical facility if they were to be evaluated like most of our clinics are. But many colleges have moved away from that model to something that looks more similar to what we are now doing in coordination with Colby, where the physicians and PAs that work there are actually employed by our residency program. And that gives the student health center a whole lot more flexibility rather than having just one physician or one provider who is there to take care of the students.
Yeah, so this is just a bit more about the history of the health center at Colby. Like we talked about before we joined, we were funded by the college. We took over in early 2020. And if you all remember what happened in March of 2020, the world kind of shut down because of COVID, not kind of, basically did. And so everything moved remote about 2 months after we started seeing students there. So right away, the focus was changed more on health and safety of the students. And our Colby medical director at that time and Raj did a lot of advising as to what the COVID protocols were going to be. Colby was actually written up a lot of places for our the screening and surveillance program. So for the 2020-2021 school year, anyone who was setting foot on campus, be it students, faculty, staff, were screened several times a week. And that was with PCR testing that they sent. there was a COVID response team. There was a whole cohort of people that way. And the health center provided some of the medical oversight over student quarantine and isolation. So really it was driven a lot by our nurses checking in that students were doing okay, didn't need any services. I don't believe there was, I can't think of a single student that was admitted as a result of having COVID, but they continued that surveillance program through this last school year as well. And we did have an outbreak as the school ended. So the highest numbers as we saw across the state and country with the Omicron variant. And then this school year, we have moved away from that surveillance screening, and it's really just symptomatic testing now.
But as you can imagine, with most contagious diseases, the college campus is a prime location, much like a daycare center, where folks are living in close proximity. That something like COVID could spread very rapidly if you didn't have a very sort of purposeful plan for how you were going to monitor. Colby was one of the first colleges to reopen for in-person education with students living in dorms. Partly because they were able to coordinate such a comprehensive screening program. We had pretty strict use of masks on almost every setting on campus. We required social distancing. There was sort of a color-coded red, yellow, green kind of a plan in place depending on the number of cases that would test positive on any given day. And if we were in the yellow zone or coming near the red zone, students would not be able to eat in the dining hall and would just have to grab a takeout meal. So there are some things about a congregate setting, which is what a college is referred to, that force you to be a whole lot more cautious and purposeful about how you're going to think about providing care and changing up living situations depending on the number of students that are testing positive.
Yeah, and it's definitely, COVID is the big thing that we all know and have experience with, but we also, last year we did have an outbreak of the flu, unfortunately. So we're one of the first pockets of flu cases in the state of Maine, and had a lot of students that tested positive with the flu. There's also definitely every year we see there's like the cold that goes around that all the students have, much like daycare, like everyone brings home the runny nose from daycare. Other visits that we see, so a lot of acute upper respiratory infections or sick visits. We do a ton of birth control counseling and contraception use. I also started a LARC clinic for Colby students that previously there wasn't a ability to do it on campus, and we would refer students to Planned Parenthood if they wanted an IUD or Nexplanon. And instead we started seeing students down at my office in Waterville to place those. And all those clinics I did with typically with a resident med student or PA. So there's a lot of experience that our residents gained from doing that, which was great. We do a ton of STD screening, both symptomatic and asymptomatic, probably more asymptomatic. We do a lot of travel physicals. So that is, utilizing the CDC guidelines and screening for what vaccines people need, any malaria prophylaxis, traveler's diarrhea, that kind of thing, for different places students are going abroad typically. That has been really interesting to understand how you utilize all those resources and counseling related to that. And then a ton of what we see is anxiety and depression and other mental health needs. I would say since we've been back on campus this year, probably 75% of what I'm seeing is anxiety and depression, management, starting new medications, and the other 25% tends to be birth control counseling or STD screening. We have, because we have the nurse-based clinic on campus, we have some very basic nurse protocols that are like a student comes in with sore throat and they're concerned about strep, they get strep testing and managed that way. Like, so nurses are screening for any red flags, having testing that way and giving advice for symptomatic management. So we are screening more of those out from providers seeing them. But of course, if things are complicated or they're not getting better, they're seeing a provider. So.
And as these are young adults sort of venturing out on their own for the first time, this may be the first time that they're accessing healthcare on sort of on their own accord. Some of the students are also from urban areas where family medicine is less common. So often this may be their first exposure to working with a family physician, and certainly one of their first times of being more independent in how they interact with the healthcare system and working with family medicine. So even though they're a generally healthy population, as you can see from this list, we're still able to provide a pretty comprehensive set of services and help the young students have an understanding that not only can we help take care of their acute URI, but we can provide long-term birth control, we can start medications and provide care for mental health concerns, as well as travel, STD screening, and a variety of other services. So it's one of their first opportunities to think about how they access care, and then we're pleased for that to be exposure to family medicine and sort of thinking about the full range of comprehensive services that they can get in just one location.
These were just some of our limitations on campus. So it is a smaller space on campus. It hasn't been renovated in a while, which was another move for us to move down the hill to our clinic space. You're okay. Sorry, I'm a very tired baby here. And then also we were working on like our best use of visits. There, historically was students come in monthly for refills for ADHD medications. That we've really changed some of our protocols for that. Also previously we had nurse coverage on campus on the weekend that we have done away with. So.
I mean, one of our goals really is to also help students figure out how to navigate the healthcare system beyond just their interactions with us. And so we have an urgent care that's a part of our health system. Our emergency departments are located both in Waterville and Augusta. And so one of our goals is also just to help them to figure out how best to navigate the whole healthcare system. And our nursing staff in particular is there to help them do that. But part of that is also realizing that, our clinic, our college-based physicians and physicians assistants are not going to be available 24 hours a day. And there are other ways to access care when needed. And we'll sort of help them to navigate that part of the process as well. So as Caroline was mentioning earlier, we made some changes and moved some of the care that is provided from just being provided through the health center on campus to our clinic, which is literally just about 1 mile down a hill from the campus. So while it was previously staffed, before we started, it was staffed by that single physician. Once we started, it was a PA and sort of 1.5 physicians, but all the care was initially provided on campus. And so we were limited by the resources available through their health center and just the limited number of hours that we could staff that center. The student health center on campus is still staffed every day of the week for 4.5 days of the week. It's not open on Friday afternoons, but there is nursing staff available to both do a sort of telephone triage and see students in the clinic to do an initial triage. We have some nursing protocols that they can provide care under these pre-approved protocols. And then they can also, if they feel like they need further assistance from one of the physicians or physician's assistants, they can book the students directly into an appointment with us at our clinic, which is, like I said, just less than 1 mile down the road. And we also have physician appointments available in the student health center 2 half days of the week. As most of the students are relatively healthy, when we did a more thorough analysis of the typical visits that were seen in the health center, we discovered that most of them really were not requiring full sort of physician or physician assistant level care. And most of what was being seen could be managed by nurse-run clinic. This was a way for us to sort of better utilize the resources that we had available, and then also think about how we could better connect students to our clinic, which was in sort of a health center building with laboratory services and some radiology services and a broader array of sort of medical care possibilities, all located under one roof. We just started this sort of new model of care with the return of the students this fall. So we're still sort of in the early stages, but the college has been working with us closely to make sure that the students feel like they still can access the kind of care that they got used to and is going to best meet their needs. So this just to sort of summarize sort of our new model. It's going to be run by 3 nurses ultimately and a medical assistant, as well as 1 front desk person located on the college campus. As Caroline mentioned, the health center is in one of the older buildings on campus, so the physical space is not great, but it's very usable for us to think about how we can have a nurse-run triage clinic. I already mentioned that we developed a number of protocols for the nurses to be able to provide that level of initial triage and care for the most uncomplicated cases that they were seeing. And then we have created a system whereby they can be scheduled directly into one of our clinic slots just down the hill. Just to give you an idea of sort of the breadth of the protocols that have been developed, you can see there's some related to contraception and birth control, some that are more specific to our location up here in Maine, like tick bites, which are very common, as well as brown-tail moth, which is a local caterpillar that creates an incredibly itchy rash, and in certain seasons of the year is a very common complaint. So we can manage all of those common conditions under a nurse-driven protocol. Other protocols that we're looking at that would be a little bit more complicated include some of the other infectious diseases that you can see in that long column on the right, such as ear infections, scabies, some of the fungal infections, conjunctivitis, and we're in the process of updating those protocols. And also realize that at any point when the nurse is not feeling entirely comfortable with the situation, that one of the providers is available to see the student either on campus or in our clinic just down the hill.
So I know there was a question about STI testing. So we did actually develop a protocol for asymptomatic STI testing for nurses to just to do based on a screening questions. Basically, as long as they say they're not having any concerning symptoms, they can have HIV, chlamydia, gonorrhea, and syphilis testing, all of which are done confidentially and sent to the state. So it bypasses insurance. So.
Great. One of the other things that is kind of interesting about working on a college campus, that as healthcare providers, we're all very familiar with HIPAA and the privacy rules around how we manage healthcare related information and the patients that we're caring for. Students also fall under something that is known as FERPA, which is a separate set of sort of confidentiality and privacy related federal regulations. So one thing that we have to keep in mind, particularly around things that are a little more sensitive, like STD testing, pregnancy testing, is that not only do we have to follow the regulations and rules around HIPAA, but we also have to make sure that we're compliant with the federal FERPA regulations. And so that's one of the reasons that, particularly for like STD testing, as Caroline was mentioning, we use a state run laboratory that doesn't access the student's health insurance necessarily, which sometimes can reveal information to parents that students prefer not to have released. So we work with the students who are our patients to make sure that we're meeting their needs and doing it confidentially in a way that feels comfortable to them. Just to give you sort of a brief idea of how we have set up the scheduling of the clinic, you can see that there's nursing staff available in the clinic 4.5 days a week. And then we have one of our residency faculty members, either a physician or a physician's assistant, that's available every afternoon to sort of work with the nursing staff to clarify any questions that they have. And then also to make sure that there's someone available for access to care, whether it's on campus or in our student health center down the hill. So sort of phase one of our work at Colby was to figure out ways that we could provide care that was needed by the students and be of service to the college and to the students. Phase two was to think about how we could link this into the education of our residents. And that's sort of what this calendar is showing, is that we have now linked the resident rotations in pediatric adolescents and our outpatient rotations, SPR and JPR, or senior practice resident and junior practice resident. So now the work with the Colby students is built in to all three of those curricula, so that our residents can become more familiar with some of the unique characteristics of working with this kind of a population and help to round out particularly their sort of pediatric / young adult education and unique health issues related to that population. Anything else you want to throw in there, Caroline?
No, we started having pediatric adolescent residents join us at the Colby Clinic last year when we were seeing people on campus, and it was overwhelmingly liked by those that did it. It is a change, typically everyone has one problem as opposed to your long list of chronic problems. So it's a nice change to that, and also a nice to see the different age students. So I'll also give a shout out. Lyndon Lefebvre just put herself to sleep, so she really wins the conference call here. Okay. Thank you all for bearing with my black screen back and forth. So yeah, she just went down. Yeah. So next year we'll talk about work-life balance and babies on calls at night. Yeah, my husband just laughed at me. So okay, yeah, we can go to the next one. So the daily schedule, this was a template for what we kind of planned on. It's similar. We have our plan is really to have a faculty preceptor and back that up with or have a resident that is seeing patients with a faculty preceptor. We haven't quite gotten there yet because there's some EMR issues, but that is the hopeful plan for the future. And then the idea would be, if it's not filled by Colby students, it can be more access for our patients as well. Next one. Some of our challenges, it is 2 locations. It is a newer model. So we have definitely, as we've started, seen some bumps in the road. These are slides from before we started this year talking about it to the rest of our faculty. And then we have definitely seen the 2 EMRs. So there is a separate EMR that follows FERPA rules, and then our own EMR that follows HIPAA rules. That is one of the challenges. So yeah, and we can move forward. And lastly, there's lots of opportunities. We're really liking that this is growing our adolescent health curriculum. We are seeing that more diversity than we see in our patient population, and the diversity of problems that you see. I actually saw a student who had been, she was from, well, she wasn't from Ukraine, but she might have been from Estonia, had been at home, and then was in Brazil, and then back to Maine, and presented with this course of fever. So it's like, do you have malaria? Do you have some other illness that I'm not thinking of? Like, how do I figure this out? So it's definitely challenges your ideas of what you expect in Central Maine. This is an opportunity for us to engage in more gender affirming care. So it is the age population that definitely students wanting to start hormone therapy, that we are seeing some of those and moving to our gender affirming care clinics that we have. For residents, it's actually an increase in the procedures and with the alert clinic that we started that I mentioned. There is additionally a Colby EMS on campus that are students that took an ENT course that are like the emergency response for at nighttime and are always on call during the day to respond on campus. And that has been more integrated with the emergency medicine faculty at Maine General. Then we're also hopeful for more pre-med opportunities. Davis Connects is they're the group on they're the office on campus that does like career development. And so we had already had a relationship doing for students from Colby doing summer research with us at Maine Dartmouth. So increasing that. And then us having our partnership with Colby, both myself and Julia McDonald have talked at different classes about different seminars about some of the work we're doing for students. And then there's also a history of med students shadowing over at Colby has a January team that students just take one class. So shadowing over that month that has historically been with Maine General, but hoping some of them come work with us at Maine Dartmouth. And lastly, it is engaging the Colby community more around health and wellness, and also making a name for family medicine. I think when I've spoken to classes, one of the big thing I've talked about is, when I graduated from Colby, I didn't really know that family medicine was a specialty that you could pick. So I've talked about how it is meaningful and fulfilling and how much I like doing what I do. So it's a great opportunity to showcase that when we have been to talk to different classes about all the cool things we get to do. So, and I think there may be one more slide, kind of our hopes for the future. Biggest thing right now, we don't have a dietitian. We would love to have one that could be a joint position between Colby and Maine Dartmouth. And seeing more collaboration between the residency and Colby, engaging Colby students. And then, like I said before, recruiting more of them to think about family medicine as a specialty if they want to go into healthcare. So I think we are happy to answer any questions people have about collegiate health or our residency in general. So.
Thank you for the presentation. It was enlightening. I was curious about the sports medicine aspect. Do you do sports physicals, or do you what exactly does that entail?
Yeah, so we will do some sports physicals in the Student Health Center. Maybe more commonly, even we do many international sort of study abroad programs require a physical to be completed before they do that, and we will take care of that. Our residency has a sports medicine fellowship, and our sports medicine fellows work directly with the varsity athletes and the athletic trainers in a separate sort of sports medicine clinic that's in the athletic center on campus. One of our sports doctors also does work in the regular student health center with us, seeing non-varsity athletes for musculoskeletal concerns. And so it's the young population who's active, and musculoskeletal injuries are a very common complaint. And so we do work with those students both at the varsity athlete level and those that are not varsity athletes. But it's one of the more common complaints that we'll see in the health center.
Thank you.
Yeah, we also do follow up with student athletes outside of their season. So Colby is a Division III school, so you're only in season like during your fall, winter, spring, whatever season your sport is in. So certainly we've had, there's definitely been some with like eating disorders that we followed at the health center, been connected with other medical problems that certainly impact their sports performance, but may not be specifically musculoskeletal related.
One of the other things that we added related to musculoskeletal concerns is that we have osteopathic recognition. So about half of our residents are DOs and half of them are MDs. And particularly for over in the athletics center, we just added additional time for one of our DO providers to provide osteopathic treatment for musculoskeletal injuries. And so again, for some of the students, it may be one of their first exposures to an osteopath and the benefits of the treatments that can be provided through osteopathy.
Thank you. Sounds great.
Yeah, you can shout out questions. I see a hand.
Well, okay. You have your hand up in the corner.
Okay, yeah. Thank you for the wonderful presentation. I know that most colleges and most times what the students complain about is that there is always a long waiting time. I know you have a lot of protocol in place to curb that, but what are the things or what are the extra things that the family medicine practice is doing to really cater for, to reduce waiting time in the clinic?
So to get these college students in, because we have dedicated clinic time, they can get in really quickly. So they can usually call the same week and get scheduled, or within at least a couple weeks of calling. Certainly not all of them are seen for acute things, but most of the problems that you see tend to be more acute problems, like acute worsening of depression or anxiety. They have some gynecologic complaints. They have a concern about STDs, like it's something you want to act upon quickly. And so by having dedicated time, we're able to see them more quickly there. And we have talked about, like, if we hit a point that we have more need for patient visits, then we can provide kind of what we do to ramp up our access there.
That's it. Vast majority of the time, the students have pretty ready access to care. But because of the college setting, there are periods of time when it seems like an illness will spread quickly through campus, and there are brief periods where it feels like it is a bit trickier to find adequate access for everybody.
Thank you.
Olamide?
Thank you very much for the presentation. I was just wondering whether there's any situation whereby there could be language barrier. I mean, considering the people you see, do you have like a standby translator if maybe some people might speak Spanish, or I mean, is there somebody that could translate if there's such problem during the clinic visits?
Yeah, we readily have iPad translators available if needed. At Colby, all the classes are taught in English, so almost all the students have excellent English, but certainly there are even if you were completely fluent in English for the purposes of learning, sometimes medical words don't always translate. So that's certainly a learning process for residents and us as faculty to navigate those, which I think is an important skill in all of medicine because it crosses all boundaries.
Good evening, and echoing everyone's thanks for this presentation. How do you all manage students with chronic conditions? Do you have to reach out to their primary care doctors? Are you involving their parents if needed? I'm just really interested to hear how you all manage that population of students.
Certainly the parent piece is a new piece to all students and us as providers. So they're all adults, right? For the most part, all of them are 18. So you have to have their permission to talk to their parents about any concerns or medical problems. I have yet to have a student tell me they don't want me to talk to their parents when they have called. I did have one tell me like she didn't think I needed to talk to her mom, that she was going to talk to her mom about something. I think what happens more often is students have a PCP at home who helps manage their chronic condition, but they need follow-up when they're on campus, which is where we step in. So we do tons of ADHD medication management because their home provider won't prescribe across state lines or want them monitored more frequently. And so we take over prescribing that medication. Typically that's confirming that they have the medication, getting their past medical records to confirm what they've been on. So it is a step, but then once they're established with us say they're on it as a freshman coming in, they continue taking it through their time at Colby. And thinking about other conditions, certainly ones with higher needs, like I saw a student that had pretty severe ulcerative colitis that wanted to establish with a GI physician locally so that she had someone where she's at school 9 months of the year. That can be harder to find those specialists in our area just because we are a more rural place and the wait to get in to see someone. So they'll still consult their provider at home. But in that case, I actually talked to her gastroenterologist on the phone when she was having a flare. So it's another level of complexity, but not one any more so than lots of things we do. I'm trying to think of other.
I think it also kind of highlights the value of working with our group versus sort of a standalone doctor in the health center, is that our group works with the local specialists with our non-Colby patients. A Colby student who needed to be admitted to the hospital, although it's rare, would be admitted to our service and be cared for by those same doctors that care for them in the student health center. So there are some additional, not necessarily chronic condition advantages, but the fact that we are well connected to the medical community beyond Colby allows us to be better advocates for the Colby students who are our patients, both in the hospital and getting them connected with local specialty care.
Yeah, and we have had some interesting, unique cases that way. We had a new diagnosis of type 1 diabetes that we admitted. We had a girl with an interesting skin infection that still don't really know what it was, but interesting presentation. And yeah, so it's stuff that you don't really see in our inpatient service because they're otherwise young, healthy people that present with rarer things but they come to our service. So
Awesome. Thank you for that insight.
I have a quick question about involvements with students at the college outside of the medical setting. I think you mentioned a little bit that there's like maybe a mentorship opportunity or way to connect with students who are interested in medicine in their undergraduate studies. Could you talk a little bit about that, please?
Yeah, so some of the things we have done, so students can apply to be basically a research intern for the summer is one way that we've involved Colby students. There historically was this what do they call it? Med Student Academy, I think is what they call the jam playing class that you did a project over the January term and shadowed a physician that took you on for January, seeing patients and working on some, be it a public health project, something like that. That went away in the last few years and definitely during the time of COVID, but there are plans to bring that back this January. Other things we've done is going and talking to different classes. So I, the last 2 years, my husband is an economist at Colby and so teaches a class on global health and development. So the last 2 years, I've talked about the opiates and opiate use disorder and medication assisted treatment of that, which is always interesting to hear undergraduate student questions. I also use it as a plug to talk about family medicine as a specialty. I've talked to an anatomy and physiology class about what needs to be a family physician, and actually I have one of the students that heard me talk there was on the CER, Colby Emergency Response and ENT, and has since stayed in the area, planning to go to med school. But was very neat to connect with her and talk to her about being a family doctor and sparking that interest in it. One of our other faculty, Julia McDonald, who recently returned from doing a 9-month stint with Doctors Without Borders, also talked to my husband's class about the like global medicine and providing like basically humanitarian medical trips and that effect in different places. So all really interesting stuff that undergraduates ask great questions. She actually recorded one of his students interviewed her for a podcast and was very, as part of her final project for one of her communications classes. She wants to go work for NPR, I believe. So, yeah. So neat to be involved with college students that way.
Well, okay, you have another question?
Yeah. I saw the schedule during the presentation, and I know that residents get to rotate through the polyclinic like maybe 3 times in a week. So I want to know if there is opportunity for continuity care at the polyclinic for residents.
We don't have that built in yet, but maybe something that develops over time.
Okay.
Right now, their residents are doing it when they're on their pediatric adolescent rotation as a 2nd or 3rd year. And in a couple of months, we're actually having an intern who's on their pediatric outpatient month working with me, seeing students that way, 1 day a week.
Okay, thank you.
Yeah.
So potentially, like especially for our Waterville-based residents, if one of the Colby students interacted with one of our residents, they could become a regular sort of PCP patient with our resident in that clinic. So there is that possibility, but it's not a built-in part of the curriculum necessarily.
Okay. Thanks.
All right. Well, thank you all for joining us this evening. It was a pleasure talking with you. Appreciate your really good questions. And we would look forward to talking to you all again sometime soon.
Yeah, and best of luck. ERAS opens tomorrow. So Dr. Oliver and I will be busy reading applications at the end of this week and next. And yeah, great to talk with you all. And thank you for tolerating my baby and me putting her to sleep in the middle of this. So
Great. Thank you all so much.
Thank you, everyone.
Thank
Have a
you.
good night.
Thank you.
Thank you.